Welcome to the deep dive. If you're a learner, maybe a resident, or honestly, just anyone needing to get up to speed on high-yield clinical info fast, well, this is for you. Today, we're doing a really focused session on anxiety disorders. We're putting panic disorder specifically under the microscope, and the sources we're drawing on. They're targeted. They give you just the clinical essentials you need. Our mission isn't just definitions. We want to get into the nuts and bolts, the etiology, the absolutely critical differential diagnosis, because this can look so much like a heart attack, and the specific pharmacologic management, especially that low-dose start strategy.
Exactly. And maybe the best place to start is just what is anxiety fundamentally? Normal anxiety is that kind of unpleasant tension we all recognize. It comes with those autonomic symptoms, headache, sweating, maybe palpitations, stomach flipping, and that feeling of restlessness. But the first key distinction clinically is anxiety versus fear.
Right. They feel similar but have different triggers.
Precisely. Fear is adaptive. It's a response to a specific external danger. Think a car swerving at you. Anxiety, though, it's often a reaction to something indistinct, maybe an internal threat, like a vague sense of dread.
Okay, so both can be protective, but when does it cross the line?
It becomes pathological when it just overwhelms the person
Right. It stops being helpful.
completely. It disrupts their normal functioning. It
Mhm.
really tanks their concentration, their ability to learn, even recall. When you see that level of impairment, that's when you know you're dealing with a disorder. So when we think about where these disorders come from, the etiology, it's complex. There's definitely a genetic component, but environmental factors play a huge role too. And drilling down into the neurobiology, the pathophysiology seems to heavily involve dysregulation in key neurotransmitter systems. We're talking norepinephrine, serotonin, and GABA.
Okay, so those systems are involved, but what's kind of driving the whole stress response cascade? What really gets that engine going in chronic anxiety?
That would be the HPA axis, the hypothalamic pituitary adrenal axis.
The classic stress pathway.
Exactly. Psychological stress seems to trigger more release of CRH corticotropin releasing hormone. That basically fires the starting pistol for the whole axis, and you end up with elevated cortisol levels. It's a very reactive system in these disorders.
So if the HPA axis is like the accelerator for anxiety, does the brain have any internal brakes? Any systems trying to counteract that?
And it does, yeah. Our sources point to some built-in anti-anxiety mechanisms, specifically things like neuropeptide Y and galanin. These seem to exert, anxiolytic effects right there in the brain. They're part of the natural checks and balances.
Got it. Okay, so before we dive headfirst into panic disorder, let's just quickly list the main players in this category according to the DSM-5.
Good idea. So under the anxiety disorders umbrella, we have panic disorder, which is our focus. Then there's agoraphobia, specific phobia, social anxiety disorder, sometimes called SAD, and generalized anxiety disorder, or GAD.
Okay, framework established. Let's zero in on panic disorder.
Right, panic disorder, or PD. Clinically, you're usually looking at an onset in late adolescence or early adulthood. That's the typical window.
And are there any demographic patterns we should be aware of?
Yes, it's seen more often in women,
Mm-hmm.
and the overall prevalence seems highest during young adulthood.
So how do we define the disorder itself? What is it beyond just intense worry?
Well, it's defined by the sudden onset of recurrent panic attacks. And the key word here is unexpected. They seem to come out of the blue. These are really intense, just overwhelming episodes of anxiety. Often there's this terrifying feeling of impending death or catastrophe.
Sounds incredibly frightening, like a medical emergency.
It absolutely feels that way to the person experiencing it, which again underlines why that differential diagnosis is so, so vital.
And PD often comes with friends, right? Comorbidity is common.
Oh, it's the rule rather than the exception. You frequently see it alongside depression, other anxiety disorders like OCD or PTSD. But the single most common psychiatric condition associated with panic disorder, that's agoraphobia.
Because the fear of having another attack leads to avoidance.
Exactly. When the attacks become somewhat predictable or feared in certain situations, people start avoiding those places, and that can develop into full-blown agoraphobia.
Okay, let's break down the attack itself. What does it look like symptomatically? What defines a panic attack?
So it's this abrupt surge of intense fear or discomfort. It has to reach a peak within minutes, and critically, for it to count as a panic attack, the person needs to experience at least 4 symptoms from a specific list.
Okay, let's list them. What are we looking for? 4 or more of these.
Yep, 4 or more. So
Okay.
palpitations, a pounding heart, or just a really fast heart rate, sweating, trembling or shaking.
Shortness of breath or feeling like you're smothering.
Yes, a sensation of choking. Chest pain or discomfort, that's the one that often sends people to the ER.
Makes sense. What else?
Nausea or abdominal distress, feeling dizzy, unsteady, lightheaded, maybe faint. Chills or heat sensations.
Paresthesias. That numbness or tingling.
That's on the list too. And then some more perceptual symptoms, like derealization, feeling detached from reality, or depersonalization, feeling detached from oneself.
Wow. And the fear aspect.
Absolutely central. Fear of losing control or going crazy,
Huh.
and very commonly the fear of dying.
That list really paints a picture. So how do these attacks translate into the formal DSM-5 diagnosis for panic disorder?
It builds directly on that. You need 4 key elements for the diagnosis. First, recurrent unexpected panic attacks.
Okay, the attacks themselves.
Second, at least one of the attacks has been followed by a month or more of either persistent concern or worry about having more attacks or their consequences like thinking they're having a heart attack or going crazy,
Oh.
or a significant maladaptive change in behavior related to the attacks, like avoiding exercise or unfamiliar situations because they fear it might trigger one.
Got it. Worry or avoidance for at least a month. What's number 3?
3, the disturbance isn't attributable to the physiological effects of a substance, like drug abuse or a medication or another medical condition, like hyperthyroidism.
The medical rule out. And 4?
And 4, the disturbance isn't better explained by another mental disorder. The attacks aren't only happening in feared social situations or in response to obsessions or related to trauma reminders.
Okay, that third criterion, not due to a substance or medical condition, that seems like where a huge amount of clinical work happens initially.
Absolutely. Given how much a panic attack can mimic serious medical issues, particularly cardiovascular ones, the differential diagnosis is job number 1. You have to identify those medical mimics.
What are the big ones we need to screen for?
Well, the list includes things like hypothyroidism or hyperthyroidism, hyperparathyroidism, pheochromocytoma, that rare adrenal tumor,
Okay.
episodic hypoglycemia, and even some seizure disorders can present with panic-like symptoms. Skipping this step is, well, it's dangerous. You could miss something life-threatening.
Are there specific red flags during an attack or in the patient's history that should make us think, maybe this isn't primary panic disorder?
Yes, there are definitely things to watch for. First, look for atypical features during the attack itself. Things like ataxia, trouble with coordination, urinary incontinence, or actually losing consciousness.
Panic attacks are terrifying, but they don't usually cause the specific neurological signs.
Generally, no. So
Yeah.
those are red flags. The second big one is the timing specifically, a late onset of panic symptoms. If someone starts having these attacks for the first time, well outside that typical late adolescence, early adulthood window, you really need to suspect an underlying medical cause.
Okay, so rule out medical first. Then, assuming that's clear, we move to the psychiatric differential. Context becomes really important here, doesn't it?
Hugely important. You have to ask, when are the attacks happening? If they only occur in social situations where the person fears scrutiny, you're probably looking at social anxiety disorder.
Right.
If the attacks happen pretty much only when someone is confronted with their obsessive thoughts or trying to resist a compulsion, that points towards OCD. Or if the attacks are triggered solely by separation or anticipated separation from major attachment figures, then you'd consider separation anxiety disorder.
I think the difference between a specific phobia and agoraphobia associated with panic disorder can sometimes be confusing. Can you give an example?
Sure. Let's say someone has a single panic attack in an elevator. After that, they avoid elevators completely, but they're otherwise fine. They go to work, go shopping, drive their car, no problem.
Okay.
That person most likely has a specific phobia of elevators. Agoraphobia, especially linked to PD, involves fear and avoidance of a wider range of situations, maybe public transport, being in open spaces, enclosed places, crowds, being outside the home alone. The fear is often tied to the idea that escape might be difficult or help unavailable if they were to have a panic attack. It's broader.
That clarification is helpful. Now, circling back briefly to the biology, we mentioned genetics. There's a strong hereditary link, right?
Oh, yes. Very strong. Studies show the risk is something like 4 to 8 times higher in first-degree relatives of someone with panic disorder compared to the general population.
And what really drives home the physiological sensitivity, I think, is that list of substances known to actually provoke panic attacks in people with PD.
It's a fascinating list, and yeah, it really highlights the biological underpinnings. Things like carbon dioxide inhalation, basically simulating suffocation.
Wow.
Sodium lactate infusions.
Huh.
Bicarbonate, even flumazenil, the benzo antagonist,
Hmm.
and of course caffeine in sensitive individuals. The fact that just breathing CO2 can trigger an attack in many PD sufferers points to a real hypersensitivity in their physiological alarm systems.
And one last point on etiology, just to clear up something historical for our listeners who might be learning this. Mitral valve prolapse, MVP,
Wow.
used to be linked to PD,
Right, it was, but that's essentially been debunked.
so no connection.
Current evidence shows no causal association between MVP and panic disorder. The prevalence of MVP in people with PD is no higher than in the general population, so that's a clinical tidbit we can safely discard.
Okay, let's shift gears to treatment. Assuming we have a clear diagnosis of panic disorder, what's the outlook? And what are the mainstays of therapy?
The good news is that with appropriate treatment, most people see marked improvement. The two most effective approaches, the real pillars, are pharmacotherapy and cognitive behavioral therapy, or CBT.
Are other therapies useful?
Yes, things like family therapy and group therapy can be really valuable supports as well, but pharmacotherapy and CBT are considered the frontline treatments.
Let's focus first on the medications. What are the main classes that our sources highlight as effective?
We generally rely on four main classes: SSRIs, the selective serotonin reuptake inhibitors; benzodiazepines, the older tricyclic antidepressants, or TCAs; and venlafaxine, which is an SNRI.
And it seems SSRIs are typically the first-line choice now. Why are they generally preferred over, say, benzos or TCAs?
Yeah, SSRIs are usually preferred. They tend to be more effective long-term for preventing relapse. And critically, they're generally much better tolerated than benzodiazepines, MAOIs, or the TCAs and tetracyclics. Fewer side effects overall.
Are there nuances between the different SSRIs for panic?
There are some practical considerations. For example, paroxetine is often quite popular because it tends to be a bit more sedating initially. That can sometimes help with the anxiety symptoms early on and improve tolerability as the person starts the medication.
Okay.
Fluoxetine, on the other hand, while definitely effective long-term, can be more activating or stimulating initially. So paradoxically, it might actually worsen anxiety a bit in the first week or two.
Yeah.
It's a really key point for prescribers to know and counsel patients about.
Which brings us to a super important point, especially for residents or anyone new to prescribing these, the starting dose strategy. You can't just jump to the standard depression dose, right?
Absolutely not. That's crucial. You must start low and go slow with SSRIs and panic disorder. This is to minimize those initial side effects, especially that potential early increase in anxiety or jitteriness.
So what are the typical cautious starting doses we should be thinking about?
Okay, for example, paroxetine, you'd start at maybe 5 to 10 milligram daily. Sertraline, even lower, like 12.5 to 25 milligram daily.
Wow, really low.
Yes. Citalopram, maybe 10 milligrams daily. Fluvoxamine, 12.5 milligrams daily. And fluoxetine, because of that potential activation, you might start as low as 2 to 5 milligrams daily.
2 milligrams.
2 to 5, yeah. Starting higher, especially with something like fluoxetine, is just a recipe for the patient feeling worse initially and potentially stopping the medication. You titrate up slowly from there based on tolerance and response.
This slow start makes the role of benzodiazepines clearer then. They work fast, but they're not the main event.
Exactly. Benzos provide rapid relief, much faster than antidepressants, which can take several weeks to really kick in for panic. So they are very commonly prescribed right at the beginning of
And
treatment.
a bridge.
Precisely, as a bridge therapy. They help manage the anxiety and panic symptoms while the SSRI is being slowly titrated up to an effective dose. The strategy is, once the SSRI is clearly working, which usually takes about 4 to 12 weeks, you then need to slowly taper the benzodiazepine off. You don't want long-term dependence.
Which benzos are most common here?
Alprazolam is probably the most widely prescribed for panic, but clonazepam and lorazepam are also very effective and commonly used.
Okay, besides SSRIs and benzos, you mentioned TCAs and venlafaxine.
Yes. Among the TCAs, imipramine and clomipramine seem to be the most effective for panic disorder based on studies. And venlafaxine, the SNRI, is also a good option.
What about buspirone? Does that have a role?
Interestingly, buspirone by itself doesn't seem to be effective for panic disorder. However, it can sometimes be used adjunctively, meaning added on to an SSRI to potentially enhance the response if the SSRI alone isn't fully effective.
Got it. And once someone is stable and feeling better, how long do they need to stay on the medication? This isn't just a short course, is it?
Definitely not. Maintenance therapy is key to prevent relapse. The recommendation is to continue the medication for at least 12 months after the patient's symptoms have improved significantly.
A full year of stability.
A full year after achieving stability, yes. Then you can consider a slow taper, if appropriate.
Okay, rounding out the treatment picture, let's touch on CBT again. What are the core components that make it effective for panic?
CBT for panic typically has two main thrusts. There's the cognitive part, which involves providing accurate information about panic attacks. It helps correct those catastrophic misinterpretations, like the belief that the attack itself is inherently dangerous or means they're dying or going crazy.
Challenging the fear itself.
Exactly. And then there's the behavioral component.
Yeah.
This focuses on teaching adaptive coping techniques, things like controlled breathing exercises, relaxation techniques, and sometimes exposure therapy to feared situations or sensations in a safe, controlled way. So if we were to boil it down to the absolute must-know clinical takeaways for, say, a resident managing PD, first, that differential diagnosis is paramount. Ruthlessly rule out those medical mimics before you land on a PD diagnosis.
Non-negotiable first step.
Second, when you start pharmacotherapy, especially with SSRIs, start low, go slow. Cautious titration is essential for tolerability and adherence.
Avoid that initial worsening.
Right. And third, understand the role of benzodiazepines. They are a valuable tool for rapid symptom relief early on, acting as a bridge while the SSRI takes effect, but they are not the long-term solution. Plan for that taper.
Excellent synthesis. That's incredibly practical, covering everything from the HPA axis right down to that 2 milligrams starting dose for fluoxetine. Really actionable stuff. So, here's a final thought to leave you with, something to chew on. We've talked about panic disorder involving pretty profound biological elements, neurotransmitter issues, chemical sensitivities, that hyperreactive HPA axis. These are powerful physiological signals. Yet, a core part of CBT, the cognitive piece, focuses on teaching the person that the panic attack, despite feeling terrifying, is not inherently dangerous. It corrects a misconception. So the question is, how does changing a belief, a cognition, manage to seemingly override or regulate such potent underlying biological drivers? It really makes you think about that intricate connection, maybe even the